another minute. Welcome, welcome. All right. Just going to give it another minute. Okay. Well, I'm going to get right on to it. Welcome, everybody. I am Megan Claire Chase, the Breast Cancer Program Director and host of our BC Life podcast here at SHARE. I'm also an invasive lobular breast cancer survivor, and I am so glad that y'all are joining us for this webinar, SABCS Report Back Early Stage Breast Cancer. Now, before we begin, I'd like to tell you a little bit about SHARE for any newbies out there. So, SHARE Cancer Support is a national nonprofit dedicated to providing education and support to anyone affected by breast or gynecologic cancer, as well as community outreach. We recognize that cancer affects every community, so our programs are inclusive and welcoming to individuals of all races, ethnicities, ages, gender identities, sexual orientations, and backgrounds. In addition to webinars like this, we offer support groups, support lines, outreach, navigation, and other free programs. And you can learn more by visiting our website at sharecancersupport.org, because at SHARE, we believe no one should face cancer alone. Whether you've come here to gain knowledge, to feel understood, or to connect with others, we are happy you are here. Now, before we dive into our presentation today, there are just a few quick reminders. All participants will be muted during this presentation, but the chat is enabled. Select everyone if you want to engage in the chat. You can submit your questions at any time throughout the presentation in the Q&A box that is listed at the bottom of your screen. And please remember that our speaker here today cannot give medical advice, so keep your questions general in nature. Closed captioning is available. Click the live transcript button at the bottom of your screen and enable the subtitles. And also, too, this webinar is being recorded and streamed to YouTube Live. The link to the recording will be available right after the webinar on SHARE's YouTube channel. So now, I'm excited to welcome our speaker, and y'all, I got to meet our fabulous speaker, Dr. Teplinsky, while at SABCS. So thought I'd just pop up that little picture. But I am very excited to welcome Dr. Teplinsky. The screen is yours.
Okay. Hi, everyone. Thank you so much for having me. I am excited to be here. So we're going to talk all about San Antonio breast cancer updates, really focusing on early stage. So I'm going to go ahead and share my slides, and we will get started. It looks like, can I start sharing? I have to send a request to share.
Yes.
Okay, let me see if I can. There we go. Okay. Great. And can you just let me know that you can see this?
Yep.
Yeah.
Okay, perfect. So we're going to dive right in, and we're going to talk about early breast cancer updates. I know there was another webinar with Dr. Lim that talked about metastatic updates. We're going to keep it really focused on early stage breast cancer here. But before we start, I thought it was really fitting that we're doing this webinar on World Cancer Day, which is always February 4th. And every few years they have a new theme, and I really liked this year's theme, which is United by Unique. And it really puts people at the center of care and their stories, and leading with compassion and empathy, and thinking about that as we think about treatment. And one of the things that I really like about it is it doesn't say patient-centered care, it says people-centered care, because as we know, everyone is so much more than their diagnosis and treatment. And so I think just centering that is really, really valuable and impactful. So with that, let's dive right in. And we're going to start with hormone receptor positive, HER2 negative breast cancer. So I broke it down by different subtypes and we'll kind of go through. And, I'll just say that for those who have not been to San Antonio, there are hours and days and multiple sessions that focus on so many different topics. So I really try to pick the things that are most impactful, things that really have potential to change how we practice in the clinic within the next few months to a year. There's a lot of really exciting preclinical data, early stage kind of first in human trials that we could be here for days if we talk about all of that, but just know that there's a lot of ongoing work that I don't have the time to highlight here. But the big news from San Antonio was definitely the results of the lidERA study. And the background for this is looking at a drug that is a SERD, a selective estrogen receptor degrader. Now, the current treatment for hormone receptor positive, HER2 negative breast cancer is, chemotherapy if indicated, surgery, radiation if indicated, and then we go to a maintenance endocrine therapy, either with tamoxifen or an aromatase inhibitor, and we add in the class of medications called CDK4/6 inhibitors if people need them, like Verzenio or Kisqali. Now, we have not had changes to tamoxifen or aromatase inhibitor in decades. We have done the same thing. We've changed who needs what drug and using ovarian suppression, but the drugs have stayed the same. So here comes SERDs. And so unlike tamoxifen, which is a SERM, a selective estrogen receptor modulator, and it works as an anti-estrogen in some places and a pro-estrogen in other places. And unlike aromatase inhibitors, which block estrogen production, what SERDs do is they degrade the estrogen receptor. So they work differently. And the thought was, are they going to be more effective and are they going to be better tolerated? So that's the basis and the premise for the lidERA study. And so in the lidERA study was estrogen receptor positive, HER2 negative patients with stage 1 to 3 disease. And I won't go through all of the criteria here, but you'll have access to the slides. And so it goes through who exactly is eligible, because some of the patients, if you were stage 1, you had to have some high risk features to be part of the study. Or you could be node positive. Either pre or postmenopausal patients were allowed onto the study, but if you were premenopausal, ovarian function suppression was added, so either with removal of the ovaries or more commonly with a drug like Lupron or Zoladex, which shuts down the ovaries. And patients, there were over 4,000 patients, and they were randomized, so half of the group got giredestrant, which is the novel drug here. It's a daily medication. And I will say that we already have SERDs in practice. We use Faslodex for metastatic breast cancer. We also have a number of oral SERDs in metastatic breast cancer, but this is the first study of a SERD, an oral SERD in early stage breast cancer. And so giredestrant or standard of care endocrine therapy, so a tamoxifen or an aromatase inhibitor. So giredestrant, this is the chemical structure of it, but the idea here is that, again, it's an oral SERD, so it's nice that it's not an injection like Faslodex is. It degrades the estrogen receptor and it really blocks the estrogen receptor. And so what it's designed to do is lead to blocking of estrogen receptor signaling, whether estrogen is present or not. Because one of the ways that resistance can develop is the estrogen receptor essentially stops responding to estrogen. And so giredestrant is designed in a way that it can overcome some of that resistance that could develop. Notably in this study, the average age of patients was 54. You can see the breakdown here. Most patients were stage 2 and stage 3. Most patients were lymph node positive. The majority of them were high risk based on how they defined it. And it's not to say that the early stage patients, the stage 1, no negative, may not benefit, but probably the reason that they were just such a small amount on the study is that, we think about who goes on a clinical trial. And when we have a new drug, we always sometimes it tends to be more the patients that are at higher risk of recurrence. So I think that some of that is just bias in the way that the patients were enrolled. So they looked at invasive disease-free survival as their primary endpoint. And what invasive disease-free survival is, I'm going to mute this here so you can see it better. Invasive disease-free survival is essentially time that someone is alive without disease, without a recurrence or a new cancer. And what they found was that using giredestrant compared to your tamoxifen or an aromatase inhibitor, giredestrant reduced the risk of invasive disease recurrence or death by 30%, which is really, really significant if you think about it. And when you look at the numbers, so they followed patients for 3 years, and at 3 years, 89.6% of patients on endocrine therapy were alive without recurrence, compared to 92.4% with patients on giredestrant. So this is a good time when we think about relative risk. So that's a relative risk reduction of 30%, but an absolute benefit of about 3%. So we say 3% more patients were alive without a recurrence at 3 years. They also looked at overall survival, which is essentially saying, not looking at recurrence, just saying who is alive or not alive at that mark. And there was also a trend toward benefiting from giredestrant, but that data is not yet mature, meaning we don't have enough events to say anything conclusively. Now, a question everyone wants to know is, well, is this drug better tolerated, right? We know that one of the huge things with endocrine therapy now is the toxicity, and many patients stop their medicine early because they are suffering. And so one of the questions was, is this drug more effective because it's truly a better medicine, or is it more effective because less patients discontinue it? And so what they found was that there was, let's see here, there were roughly the same amount of symptoms of joint pain, but less patients discontinued giredestrant for joint pain. So that is promising, lower discontinuation rates. You can see here still hot flashes, headaches, and it kind of goes down some of the side effects of fatigue and insomnia and nausea. So based on this study, there wasn't a huge difference in side effects, but we do think perhaps less discontinuation from side effects. So an important point there. And I want to highlight here, there are a number of oral SERD trials in development. So the lidERA study that we just talked about is just one of them. You can see here there's a number looking at other SERDs like camizestrant, imlunestrant, elacestrant. And so this is really, really important, because as we get all these studies, and they all kind of are a little bit different. Some are at the time of first treatment, some are after a few years of endocrine therapy. So I think it will help us really in the next few years really refine how we are treating hormone receptor positive breast cancer. So what are some factors to consider? Giredestrant is not yet FDA approved. This is really important. This is not a drug that we can get in the clinic today. I don't know when it will be approved. There's some thought maybe end of 26, early 27, but I really don't know. Notably, remember we talked about that we use Kisqali and Verzenio, or CDK4/6 inhibitors, with endocrine therapy when appropriate. Now, right now, we don't have this combination data because this study didn't look at using CDK4/6 inhibitors with giredestrant. That data is ongoing. And so what we don't know yet is, would we do, let's say, our endocrine therapy or aromatase inhibitor with the CDK4/6 inhibitor for the first few years and then switch to giredestrant? Is giredestrant benefit additive when we add the Kisqali or Verzenio? So there's a lot of questions here. And of course, the big question is, how much is this drug going to cost? Tamoxifen and aromatase inhibitors are very cheap. This would not be very cheap. And so what does that mean for the sheer amount of people that are going to need it, and who's going to pay for it, and how is this going to play out in practice? So still a lot of questions, but really promising data. And I think that probably was one of the top presentations at SABCS this year. So moving on to HER2 positive breast cancer. So we've had a lot of, we have 3 big conferences in breast cancer each year: ASCO, ESMO, which is the European Society of Medical Oncology, and SABCS. And so some of this data is going to build on what was presented at ESMO just a few weeks prior to SABCS. So here I have the current standard of care for HER2 positive early stage breast cancer. This is based on NCCN, which are the guidelines that we use. And you don't have to read this in detail or memorize it, but the idea is that for HER2 positive breast cancer, whether hormone positive or negative, we really think about neoadjuvant therapy for the majority of cancers. So, and neoadjuvant again is before surgery. So this is for tumors 2 centimeters or greater or lymph node positive. We do neoadjuvant, and we can consider it for tumors that are 1 centimeter or greater. And historically, we've done chemotherapy with anti-HER2 therapy. And this past year at ESMO and more at SABCS, we saw some data that is looking at, can we add different drugs to that neoadjuvant therapy? And that drug that they want to add is an antibody drug conjugate called trastuzumab deruxtecan, or Enhertu. And what antibody drug conjugates are, some people call them the biological missile for targeted cancer therapy. Essentially, they have 3 components. They have an antibody, which is this yellow thing here. Then they have a linker molecule, and the linker molecule is links the antibody to a cytotoxic drug, so the chemotherapy piece. So what happens is this antibody is going to recognize something on the cancer cell and bind to it. And when it binds to it, that triggers the linker to kind of cleave, and it releases that cytotoxic drug inside the cancer cell. And that's being called the warhead for destroying the cancer cells. So again, it's going to recognize something on the cancer cell, bind to it, and then inject that cytotoxic drug into it. So for Enhertu, or trastuzumab deruxtecan, it recognizes HER2 on the cancer cell, and then it works its magic and injects that cytotoxic drug into the cell. I like to think of it, and I explain this to my patient, as if you're making jelly donuts and you're stuffing jelly donuts, right? And if you plunge in the jelly into the donut, a lot of the jelly leaks out. And that's what happens with Enhertu as well. That's called the bystander effect. So some of that cytotoxic drug leaks out to the surrounding environment. And that's why Enhertu works for HER2 low or ultra low, because you just need a little bit of HER2 and then it'll kind of leak out to the surrounding area and kill the surrounding cells. So right now, Enhertu is approved for many metastatic breast cancer settings, both for HER2 positive, HER2 low, and ultra low. But now there's some research saying, can we move it into early stage breast cancer? And that is the basis of the Destiny Breast 11 study. And this looks at comparing neoadjuvant chemo anti-HER2 regimen, ACTHP, with different combinations. So they looked at TDXD followed by THP, taxane chemo, Herceptin and Perjeta, or TDXD alone. And this was a group of patients that were fairly high risk. So it's not for everybody. You had to either have positive lymph nodes, or if lymph node negative, had to have a bigger size tumor. And what they found was that using the regimen TDXD for 4 cycles, followed by THP for 4 cycles, led to a pathologic complete response rate of 67.3%, which is really meaningful. That means that 67% of patients at the time of surgery had no more cancer remaining. And if you break it down by hormone receptor positive, it was 61%, and then by hormone receptor negative, it was 83%. So that means 83% of patients, all their cancer was gone at the time of surgery. And that was a marked improvement over ACTHP or over TDXD alone. The big thing with TDXD that we worry about is the incidence of pneumonitis or interstitial lung disease, so inflammation of the lungs. And it happens, and it can rarely but be fatal. And so in this particular case, what's important is because they only did 4 cycles, the incidence was really low. They only had 2 patients. Actually, it was less than the patients who got the standard chemotherapy. So that was really, really important because that's been a big concern for us about giving that medicine. TDXD with THP did have higher rates of neuropathy, so an important point to keep in mind as well. And then I'll highlight some other side effects here, but we do pay attention to nausea and vomiting, but it was again a little bit lower with TDXD and THP. So really important regimen, not yet approved, but likely will hopefully be in the future, and that will perhaps change how we think about treatment. Now, we also know that for patients who do not get a complete response and have residual disease at the time of surgery for HER2-positive breast cancer, we then move on to treatment with Kadcyla. And Kadcyla is also an antibody-drug conjugate. We used to give Herceptin, and then we had the Catherine study which said, no, Kadcyla is better than Herceptin. And so now we have the Destiny Breast 05 study, which looks and says, can we be better than Kadcyla, which is TDM1? Let's compare it to Enhertu and see what happens. So that's what they did. And again, they used a high-risk population, so not for everybody, but people who had either inoperable breast cancer to begin with because it had a lot of lymph node disease or was a big tumor, or they had operable breast cancer, but after surgery, they had residual disease in the lymph nodes in the armpit. And so again, they randomized patients to receive Enhertu or Kadcyla. And what they found was that Enhertu reduced the risk of recurrence by 50%, by 53% to be exact. So here, what they look at is 3-year invasive disease-free survival. Again, how many patients are alive without recurrence at 3 years? And for TDM1, it was 83.7% and increased all the way to 92.4% with TDXD. So really important study. Now, again, one of the things here is that there was more lung disease because patients received Kadcyla for they received Enhertu for 14 cycles compared to the 4 cycles if we give it neoadjuvantly. So that's something that we certainly do have to keep an eye out for, but there was no impact on radiation, the timing of radiation on the impact of lung disease, which has always been a question as well. So that's really important information. And then the other thing is that there is a signal that trastuzumab deruxtecan may reduce the incidence of brain metastases, which is really big because Kadcyla doesn't really penetrate into the central nervous system. So this is very early data, but very promising as well. They looked at San Antonio. They presented some additional data, whether you were HER2 3+ or you were 2+, but positive on FISH. There was no difference, which depending on how you tested positive for HER2, there was no difference based on what kind of chemotherapy you got. There was still a benefit to receiving TDXD in the residual disease. We'll kind of skip over this for time. I mentioned this already for the interstitial lung disease. Skip over this. So factors to consider, and this is what kind of all of us are thinking now is, well, what do we do? We have data for giving Enhertu upfront, but then if someone gets Enhertu and they have residual disease, can we give more Enhertu? Right? What if we don't give Enhertu up front? Should we give it after? Right? So there's a lot of questions, and as these are new studies, so as time goes on and more data comes out, we'll be able to really kind of hone in on what we should be doing. Briefly, I want to touch on the results from the ALTO trial, which looks at the triple positive population, so hormone receptor positive and HER2 positive. And the bottom line is that we have conflicting data on what is the optimal endocrine therapy for our patients, especially our premenopausal patients. Can they do tamoxifen? Can they do tamoxifen with ovarian suppression? An aromatase inhibitor with ovarian suppression? We have some data that said, well, maybe patients with triple positive disease don't need the AI. So ALTO was a big study done many years ago that looked at different combinations of HER2 blockade. But what they looked at here was they tried to figure out what's the optimal endocrine therapy. And it's not reading very well, but you can see they had about 1,200 patients that were premenopausal, which is really a big population that are triple positive. And what they looked at here was disease-free survival. So they tried to ask the question is, what is better? Is tamoxifen better? Is an aromatase inhibitor better? So for postmenopausal patients, the aromatase inhibitor was better at reducing the risk of recurrence or death. When they looked at overall survival, meaning how many people were just alive at the end, there was no difference between the two. But premenopausal is where they break it down and it gets much more interesting. Now, again, we don't have a lot of numbers here, but what they found was that there was 90% were alive without recurrence when they used an aromatase inhibitor compared to 77% of patients who used tamoxifen. And again, you can see here that there was only 118 patients who used an aromatase inhibitor compared to 1,100 who used tamoxifen. So it is hard to compare because these are not equal groups, but there certainly is a signal here for using the aromatase inhibitor. And I'll skip over this. And so I just want to highlight here, they then broke it down into using tamoxifen alone, tamoxifen with ovarian function suppression, and there was no difference. The difference really came in when you added the aromatase inhibitor in the premenopausal patients. So I think this helps us with our counseling and how we approach things. Skip over here. All right, so let's move on to triple negative. I will say for early stage breast cancer, we have not had a ton of updates recently for triple negative breast cancer. So keep that in mind. We've had a lot in metastatic. This has been a huge year for metastatic triple negative, but not as much for early stage. So the big discussion really has been, what is the role of adding carboplatin to our neoadjuvant or adjuvant chemotherapy? That's really the big thing that came out of San Antonio. And so they did a number of analyses. They put a lot of trials together and they said, all right, what does carboplatin add? And the reason people are talking about it is that adding carboplatin does add more side effects to treatment. It adds a lot more lowering of the blood counts, can add, some issues with hearing, neuropathy, fatigue, etc. And so, if we don't need to do it, we'd like to de-escalate treatment and pull it off. So this analysis, what they showed was they looked at the impact of carboplatin for pathologic complete response rates. So anyway, and what you can see is that in patients who did have carboplatin, they had an improvement in pathologic complete response from 38% to 55%. Now, the issue is that these studies, most of them did not include immunotherapy, which we use now standardly for triple negative breast cancer. So it's kind of hard to say, like, how much does carboplatin add? What if we add immunotherapy? Will that minimize some of the risks? But based on this analysis, carboplatin did increase pathologic complete response. And we know that pathologic complete response for triple negative breast cancer does correlate with better long-term outcomes. And if we don't have a pathologic complete response, we then try to change therapy to improve outcomes in the adjuvant setting. However, what they found was that although it did improve pathologic complete response, when they looked at overall survival, so how many people were alive at 5 years, there actually wasn't a significant difference with adding carboplatin, right? So that kind of is a little bit confusing, right? Improve pathologic complete response, but not improving survival. And so a lot of factors here to consider in terms of, how do we reconcile this data with the Keynote 522 study, which is the study that told us we're going to use immunotherapy. And immunotherapy improves overall survival by 5%. So does everyone need carboplatin, right? It adds more side effects. How do we think about who will need it neoadjuvantly? And I think it's really hard, although this was a big analysis and we're talking about it, without looking at the data from Keynote and the addition of immunotherapy, it's a little bit tricky in terms of what we should be doing. So I think it's really being considered on an individual basis. The other study that was presented was, what if you didn't get neoadjuvant therapy and you received adjuvant therapy for triple negative breast cancer. Sometimes we do that for very small tumors, typically under 1 centimeter, or sometimes there are situations where we think the tumor is smaller and the patient goes to surgery and it turns out to be bigger. And, for whatever reason, they didn't get neoadjuvant therapy and we're giving it adjuvantly. And typically unless they were really, really tiny, we were giving a regimen called ACT. So an anthracycline chemo with Cytoxan and a taxane chemotherapy. And again, we've raised the question of, do we need to add carboplatin? So this study, the RJBC 1501 study, looked at that very question. Do we add carboplatin to it? And they used, instead of adriamycin, which we often use, they used another anthracycline chemo called epirubicin. So this regimen was our standard ECT, and then they added here ECT, Taxol, and carboplatin. And this was for patients who had stage 1 to 3 triple negative breast cancer that were 1 centimeter or greater or lymph node positive. And what they found was that the addition of carboplatin reduced the risk of disease recurrence or death by 34%. So again, here is a benefit for carbo, again, raising the question of, do we need to now add carboplatin if we're giving treatment adjuvantly? So in some cases, again, can we de-escalate? But here it's more of a question of, do we need to escalate? So lots to talk about with that very evolving data. So let's switch gears a little bit. I'm going to talk a little bit about kind of some survivorship topics for previvors, for screening, that I think are really important and valid. So one of the questions that I get consulted on and asked about all the time is, what should our patients who carry a BRCA mutation, what can they do with menopausal hormone therapy or hormone replacement therapy? So this was a study that was presented, and they looked at patients who had a mutation in BRCA1 or BRCA2, no prior cancer, and no prior mastectomy. So they had breast tissue intact. Then they had 2 groups of patients. They had 676 patients who did not receive menopausal hormone therapy, and another group, the same number of patients who received menopausal hormone therapy. And what they were trying to do, they matched them. So they were very similar groups and populations, and they wanted to see what is the impact on the incidence of developing breast cancer, because that's the big concern, right? If we use hormone therapy, will we increase the risk of patients developing breast cancer? And you can see this is the group, the characteristics of patients that they had. The average age was in their early 40s. Most of them did have, I'm sorry, I don't know why this keeps moving on its own. I apologize. The majority of them did have a BRCA1 mutation. Okay, and let's take a look here. And then, yeah, and most of them did have their ovaries removed. And what they looked at was the incidence of breast cancer over almost 15 years of follow-up. Now, some of them did later go on to receive a mastectomy, but at the time of enrollment, they did not have a mastectomy. And they found that in the group that was green, the group that used menopausal hormone therapy, there was a lower risk of developing breast cancer compared to people who did not use menopausal hormone therapy. And the benefit really was, the benefit in reduction of the risk was due to estrogen alone. If they added a progestogen, it didn't increase their risk. Okay. And so there's a lot of limitations in this data. We need longer follow-up, but this is really promising, and it helps us really kind of counsel our patients about the probable safety in a lot of these situations in using hormones. I don't know why this keeps moving on its own. Not sure if I'm doing anything wrong here. So bear with me. I'm sorry. All right, we'll keep going here. They also looked at the hormone Duo-V, and it has beta-doxyphene, which works as an anti-estrogen in the breast and uterus, and then they have estrogen for everything else. And none of the patients that used Duo-V developed breast cancer. So really promising, and we have some early data with Duo-V in patients with DCIS. So I'm excited to see more data to counsel on how we can think about, hopefully in the future, being able to use hormone therapy for more of our patients. let's move on to the wisdom study. And the wisdom study is an exciting study where they're really looking to personalize breast cancer risk assessment and then guide screening. So saying to someone, everyone should start at 40 if your average risk, we know is not sufficient. We know that there are populations who would benefit from earlier screening and later screening. And so wisdom is really looking at this in a very innovative way. And the first part of the wisdom study, they enrolled patients aged 40 to 74 who did not have a history of breast cancer. And they did genetic testing, they did really detailed questionnaires, and then they randomized them to receive either risk-based screening based on their risk or annual screening. And what they wanted to look at was, so they did age, race, ethnicity, family history, biopsy history, breast density. They looked at germline testing, so genetic testing. They looked at multiple genes. They looked at single nucleotide polymorphism, so single changes in genes that could contribute to breast cancer risk. And then they generated for everyone a tailored screening and prevention or risk reduction plan. And they wanted, and you can see here, what were the screening recommendations that they gave. So either someone was really low risk and they said, you don't need to start screening until age 50. Average risk, they said twice a year, mammogram every 2 years. They were elevated risk, they said annual mammogram and then, consult with a breast health specialist. And if they were at the highest risk, then they would also be offered an MRI. And what they wanted to look at was, can we reduce the incidence of stage 2B or higher breast cancer based on this approach? And what they found was that using this personalized approach, where some people could start at 50, some people needed mammogram and MRI, there was no difference in the number of stage 2B breast cancers that were diagnosed. And there was a reduction in there was no decrease in biopsy rates. So, this is important information. They're evolving it further. They're now doing the Wisdom 2.0 study where they are collecting even more information and they're testing for more genes that will then guide the recommendations. So this is something I personally participated in the Wisdom study. And I urge people, if you're listening, if you have a family member or a friend, I think this is great. Not only do you get free genetic testing, but you really have, really get to think about your risk and get consultations if you're high risk. So I think it's very valuable. And I'm interested to see what the next kind of studies will show with that. But to put it into perspective, right now we have a technology that is hopefully going to be approved and used soon called Clarity Breast. And this is an AI platform with the goal of predicting a woman's 5-year future risk of developing breast cancer using her existing screening mammogram. So based on one mammogram, they're going to tell you, this is AI technology, that hopefully should be in the clinics soon, it's FDA cleared, that the individual will receive a diagnosis of breast cancer or develop breast cancer within the next 5 years. So you would go for your mammogram, and then if you know you're at high risk, then you start thinking about, do I need MRIs? Do I take medications to lower my risk? You would meet with a breast surgeon. So I think this is really going to change how we think about breast cancer risk and screening in the future. And I guarantee that if we talk about this in 5 years, it will look radically different than it does today in 2026. Lastly, one last topic very quickly here, but I do want to highlight GLP-1s and breast cancer. There was a number of studies at San Antonio looking at GLP-1. So these are the weight loss, anti-obesity medications. And really, a lot of this data is very limited because they're looking back on populations and they're just presenting their observations, but really exciting and promising. What they're showing in the studies that were presented was that in patients with breast cancer, using GLP-1s was associated with lower rates of ctDNA, circulating tumor DNA positivity. That's the Signatera test or others like it. They found that it might be associated with better tolerance of chemotherapy when used concurrently. It may, this says may increase overall mortality. This is incorrect. It should say may decrease overall mortality. So people may live longer when using a GLP-1 when used with breast cancer, but it might worsen endocrine therapy side effects. So something to keep in mind. And when given concurrently with endocrine therapy, GLP-1s were associated with sustained weight loss. So again, small studies in some cases, observational, but very promising data. And there are two ongoing studies that are really exciting called TRIM EBC and FitWise. And they are actually looking at using GLP-1s in breast cancer and the impact on their recurrence risk. So I think this is going to change, again, how we use these medications for our patients with breast cancer. So my takeaway points are, I think oral SERDs are going to change early stage hormone receptor positive HER2 negative breast cancer treatment. I think we're going to use trastuzumab deruxtecan much more for early stage HER2 positive breast cancer. The role of carboplatin will continue to evolve in triple negative. Personalized breast cancer risk screening and screening strategies are advancing. And that will change what we do. And survivorship and menopause research is critical. And I think it's starting. I think we have a long way to go. But I'm really encouraged that we have these big meetings that are having these conversations and are highlighting some of these studies, because that really says this is meaningful, this is impactful, and we need to see more research. So that was a whirlwind through SABCS. I'm happy to answer any questions. This is how you can connect with me. Follow me on social media. I do have a book coming out in September that is my baby. I've worked on it for the past year. It's called Beyond the Pink, and it's really all about the topics that we don't talk about in the clinic: sexual health, mental health, brain health, bone health, you name it. So you can pre-order it wherever you buy books. It's out now for pre-orders, and I would appreciate any support for it. So thank you.
Oh my
I'll
goodness,
stop sharing.
congratulations on that. That's
Thank
huge.
you. Thank you. I will stop sharing my screen
Okay.
here. Okay.
All right. So again, very, very informative, and there's lots happening. Lots
Yes.
happening.
Lots happening. Mhm.
So some of the questions you did answer, but I'm gonna go through a couple here. So do most side effects from the carboplatin happen during treatment, or are there long-term effects that can show up later? What should patients be
Yeah.
thinking about?
A little bit of both. I think, mostly it is in the acute setting. Carboplatin does, it adds more fatigue, more low blood counts, more toxicity in general. But also there are situations where it can impact neuropathy, especially when also given with taxane. So that's number one. You can see some hearing issues, so tinnitus, ringing in the ears, a little bit of hearing loss, and that we see more in the elderly. But that can be really, really debilitating for patients, especially if they have pre-existing hearing loss, right? So these are things that I like to think about, right? If we have a woman who is 75 and is already struggling with hearing, and we know hearing loss is a risk factor for dementia. So you can see how this spirals. So I think this is where we're going to think about it on an individual basis.
Yeah, that makes sense. It has to be totally nuanced, right?
Yeah. Hmm.
So this question was, and you may have touched on this already, but could you share how long the clinical testing and development process for the giredestrant has been so far? And are there currently opportunities for patients to participate in clinical
Yeah.
trials involving it?
So there's a number of different studies. The lidERA study has completed recruitment because now we have the data. So they're not enrolling any more patients for that study. But if you are interested in a oral SERD trial for early stage breast cancer, there are still some, I believe, that are ongoing. But the best thing to do would be one, to go to clinicaltrials.gov and you can search there. And I will say it's not the best website, but you can put in breast cancer, you can put in SERD, and it should pop. You could put in by location, what's recruiting. Also ask your medical team, but I like clinicaltrials.gov because you can try to get a sense of what's in your area, and you can also look for other trials as well. So if you put in breast cancer and your location and your distance, you can filter it that way.
So I'm going to ask a question and thinking about treatment duration and hormone therapy and survivorship. like how long is it currently recommended to stay on aromatase inhibitors for someone with stage 2 or stage 3 invasive ductal or even invasive lobular with lymph node involvement?
So great question. And so there's a lot here in this, right? We know for endocrine therapy, kind of on a broad level, we'll say 5 to 10 years. And then we start to narrow that down a little bit. There are tools that we can use. One of them is the breast cancer index, which looks at different genes and helps guide to whether there is a benefit for extended endocrine therapy or not. A lot of that is really based on side effects. It's based on someone's risk of recurrence. There was just a study published in the Journal of Clinical Oncology a few weeks ago looking at premenopausal lymph node positive patients with breast cancer. And it actually did show that there was a benefit to 10 years over 5 years. For some patients, 7 or 8 years may be a good option. So I say to my patients, our goal is to get to 5. And then after 5, I always think that's a bonus, right? The more, but like we balance it. If I have a woman who had a really low risk of recurrence and she's really severe osteoporosis or she's really struggling, right? We might say we're going to stop earlier. So we're going to stop at the 5 year mark. So it really depends, but we do, for some people who are at higher risk, especially our premenopausal patients, we do want to get close to 10 if we can.
Yeah, because I was diagnosed under 40 as well, and I had a 10-year plan, right?
Yeah.
So, yeah, that does make sense. And speaking of osteoporosis, I think I saw someone on here. Let's see, where'd it go? Okay. Well, I can't find the question now. Oh, here it is. Yes. What are the known long-term and late effects of radiation therapy that patients should be aware of? I didn't really hear too much about radiation.
Yeah, because I'm a medical oncologist, there is, I will say, kind of as we think about what's happening in the local space in terms of surgery and radiation, there's a big push on one, not doing sentinel lymph node biopsies in some patients. So we're kind of getting away from that. We have the sound and enzema trials, which show that for certain patients we can do that. And then similarly with radiation, we have, a lot of discussion about pulling back and de-escalating, which is great because if less therapy is good if it doesn't add anything. But long term, we do think about, so depending on if you did get left-sided radiation, we do make sure that you're talking to your team about your cardiovascular risk and seeing a cardiologist if necessary. Some people can get lymphedema and swelling. So those are things that we keep in mind about. And a great question to ask your team is, what, based on the surgery and radiation I received, what am I at long-term risk for? And they can then guide you. But by doing less lymph node surgery, by doing less radiation, we are reducing the risk of long-term side effects.
Hmm. And can chemotherapy contribute to serious osteoporosis, weight loss, and balance problems even a year or more after completing
Yeah,
treatment?
I 100%. So I think this is really an underutilized uh, area that is understudied and under talked about. And chemotherapy can impact our bone density. It impacts our muscle mass, and as we lose muscle mass with chemotherapy, there's less force on bone, which then can impact your bone density, right? And less worsen bone density. And one of the things that we don't do is we really don't look at body composition. So I know when I have a patient getting chemotherapy, we look at their weight and we say, oh, you didn't gain it, you didn't lose any weight, you must, or you didn't gain weight, and we're happy with that. But what's happening is that you may be losing muscle and gaining fat. And so the number on the scale may stay the same, or it may not look like you're not losing weight, and we're happy because we think you're eating appropriately, but your body composition is changing, and that can have long-term effects, and that can then also impact insulin resistance. And then if we're for hormone receptor positive patients, we're adding endocrine therapy, which can further impact metabolism resistance. So you can see how this spirals, and I think this is why the GLP-1 medications will become much more widely utilized for our patients, because I do think they really can help with that, with some of the insulin resistance and sensitivity. So what can you do? And number one is make sure, start with, a bone density isn't everything, but make sure you have a bone density when you finish chemo as a baseline. Unfortunately, insurance doesn't allow us to get a pre and post. So I would say get a post because that's your new baseline. If you haven't had one within 2 years, and work with that strength training. So talk to your team about how do you get plugged in with a cancer exercise specialist. Protein, fiber, like diet really matters. So these are all things that we can do, and ask if there is a way to measure your body composition.
Hmm. And speaking of the GLP-1, are they still recruiting? Is it too late to join
So
a
I think they
trial?
are still recruiting. Again, depends on where you're located. So again, you're going to go to clinicaltrials.gov and you're going to plug in that information, breast cancer, GLP-1, and you should see what's available.
And it's a great question. For the Clarity Breast AI detection system, and the 5-year risk of developing breast cancer, what about for those individuals with dense breast tissue where masses might not show up as opposed to ultrasounds or MRIs that would ideally clearly see it?
Yeah, it's a great question. I don't think we have the answer to that yet. I mean, so remember, this technology has been studied a little bit. It's FDA cleared, meaning which is a process. It's not as rigorous as it is for some other medications because it's technology, but it's not widely utilized yet. So I don't think we have data yet, like in that great population. So I think that is something that will evolve. And I think it's not going to replace the need for supplemental screening right now. It's not going to say you don't need an MRI, you don't need an ultrasound, but I think we'll have to see what happens. I have not seen any data on clarity and breast density. That doesn't mean it's not out there. I just haven't seen it. So it may be in the works, but I don't think we know enough yet to be able to answer that.
I hope we definitely get more information on that
Oh yeah,
because
100%.
exactly because as I was invasive lobular and I was able to get a mammogram in my 30s, covered by insurance. I always like to tell people you can get a mammogram at any time, but to get it covered by insurance,
Hmm.
you have to either be 40 or show family history of risk, and mine was missed. And so I always get nervous when I hear about new technology, and it's like making sure that it really can see for those that may have dense
Yeah.
breasts.
And what I worry about too, and we know lobulars are notoriously can be missed on on mammo. What I worry about with some of this is if people are told they have low risk, it does not mean you shouldn't continue to get your mammograms and your imaging, right? I worry that someone's going to say I am low risk and skip it the next year because they're busy. So I think that this is really a tool to add, but not to replace. And I want to stress too that I didn't talk about this, but there is not everyone should start screening at 40. There was a study published a couple of years ago that looked at different race and ethnicities and looked at how do you combat the disparities that we have with black women having 40% higher rate of death from breast cancer. And they found that if you started screening black women at age 32 compared to 40, you would start to overcome that, right? So it's not a one size fits all. And I wish the guidelines would reflect that because I do think that could move the needle just a little bit.
Yeah. I mean, that just kind of like blew my mind for a minute. So sorry, I was
Yeah,
just like, oh my gosh,
I know.
that's the first time I've actually heard that like said in that way. That really just
Hmm.
resonated. So,
Yeah, because it's not a one size fits all. So I do think like this data, it's not perfect, right? But anything that we can do to make it to make it individualized is really the key.
another question. I'm not sure what medication, if they could put in the chat, you said, has this been tested in combination with other medications? I'm not sure what you're referring to. So if you could just put that in the chat. But another quick question with the GLP-1 injection, and the injection site, stomach, arm, or hips, like,
So
is there a certain location that's better that or more effective of where you
I'm
inject?
not sure. So I don't prescribe the GLP ones because that we leave to our metabolic and weight loss and obesity and endocrinology colleagues. So I don't know which one is better. I will say I have not heard that one is necessarily better or more effective, but that would be a question you would ask whoever is prescribing for you.
Absolutely. Are there any current or upcoming studies focused on DCIS that patients should know about? Because I was really interested also too in like the Previver,
Mhm.
when you were talking about what was that study, the
The DUAV, yeah, the
DUV.
DUAV study.
Mm-hmm.
So there was actually, again, so remember, DUAV has that anti-estrogen in the breast, so it's really exciting. So they did a study that was presented at ASCO this year called, I believe, the PROMISE study, where they looked at DUAV for DCIS. And all they looked at was 4 weeks, and they looked at essentially how quickly the cells were growing, and they found that giving DUAV lowered the proliferation rate of the cells, which is amazing, right? So you're giving estrogen to the body, but it's an anti-estrogen in the breast. And so really exciting. I like to think about this for patients who call me and they've been treated for DCIS and now they're thinking about hormone therapy. And we need some more research, but this can be an option. We don't use that yet, or wouldn't necessarily use that in invasive breast cancer because with invasive breast cancer, it can come back anywhere else in the body. So DOV just in the, like that anti-estrogen in the breast is good, but it wouldn't help the rest of the body. And I think we all agree that we need more research on hormone replacement therapy for breast cancer survivors, thrivers, previvors, because this is really an unanswered area.
Absolutely. Um, and I know you have talked about this a lot. I know we did a program with you maybe a year or two ago, but what is your perspective on the use of local vaginal estrogen to improve quality of life with
Love
those
it.
that are hormone positive and HER2
Love it.
negative?
Love it. Everyone should get vaginal estrogen. I mean, the data is there. It is reflected in so many guidelines, American Urologic Association, ASCO, NCCN, and it saves lives. I mean, there was a study last year, I believe, that people who were on vaginal estrogen lived longer. Not even quality, like they lived longer because they weren't being admitted to the hospital with UTIs and getting sepsis and getting delirium and it starts when we're young and it starts when you're going through menopause or even before menopause. So vaginal estrogen, I 100% support, prescribe it all the time. And I urge you to talk to your doctor about it if you're experiencing the symptoms. Moisturizers are good, but they're not the same thing. They don't change the quality of the tissue.
And we feel so scared just hearing the word estrogen. It's like, wait, if we were,
Hmm.
estrogen
Yeah.
positive, we don't want to be using anything that has the word estrogen in it. So it's how do
Mhm.
we eventually get that messaging to help lower the fear
Yeah.
also? Yeah.
And I think that's hard. You're right. I mean, you hear estrogen, and then what the challenge too is if you have right now the label is still on it. So I've prescribed it a bunch, and people have gone to their pharmacist, and the pharmacist says, no, you can't have it because the label is there. So the label coming off, I think, will help. And I think it's just more conversations about this topic, right? I feel like I can talk about this every day and it will reach more people.
I definitely want to ask this question. So for those of us in the early stage, we don't really know like how does early stage breast cancer progress to stage 4? Like, what are those common pathways or factors that we should think
No.
about? Because there is that great divide of early stage and MBC, but early stagers do need to better understand stage 4.
100%. So there's a number of ways, and there's a lot of research on this, but there's a number of ways that someone can develop metastatic disease from an early stage diagnosis. So one of the ways is that even from the beginning, there is micrometastatic disease present. So there's already circulating cells in the blood, that are maybe finding their way to other organs that we just can't detect. And so at some point, they're there and they become resistant to treatment and grow. Another way is this concept of tumor dormancy, meaning at a new diagnosis, some cells kind of are shed into the bloodstream and they make their way and they hibernate in the bone marrow. And the microenvironment of the bone marrow is pretty hostile to the cells. So a lot of them die, but some of them don't. And some of them survive and they kind of burrow in there and they go dormant. And so they're not active. So they're not necessarily killed by cancer therapies. They kind of shut down. And there are what we're really studying right now is what can wake up the cells. Is there something? There was a study in mice, so we'll remember humans are not mice, but there was a study this summer where they took dormant cells, breast cancer cells, and injected them into the lungs of mice. And then they injected those mice with like a large amount of COVID or flu. And they found that that inflammatory milieu woke up those dormant cells, right? So we're, in a way, I think we're starting to understand this role of inflammation and what that does. There's actually a number of studies ongoing, some studies at Penn, these are fascinating. They're sampling the bone marrow for these disseminated tumor cells, and then they're trying to wake them up and get them out of dormancy and kill them. So the key is to wake them up and kill them. So fascinating. And they're using, I mean, what's crazy is they're using drugs like Plaquenil, which is a drug we've used for a long time for rheumatologic diseases. And so I think it's evolving. So, I mean, in a way that is going to look very different in a few years, but really trying to figure out what triggers those cells to wake up from dormancy is important.
Well, Dr. Teplinsky, I cannot thank you enough for your time, your expertise, and breaking this down into patient-friendly language. And thank you to all attendees for coming today. Um, you are part of this community, and we are so grateful that you are here. We just want to show you some upcoming events that we have. And again, a quick reminder that the webinar is being recorded and it is streamed on our YouTube channel live, so it is already there. But the link to the recording will be available after that. And be sure to visit our website, sharecancersupport.org. We have these upcoming events next Tuesday, a special screening of the documentary with the trans dudes with lady cancer. I interviewed them on the podcast, our BC Life, towards the end of last year. So this is very interesting for everyone who wants to better understand the trans experience within breast/chest cancer and ovarian cancer. So again, on behalf of Share Cancer Support, everyone, please make sure to fill out the survey after this and connect with us on social media. And again, Dr. Teplinsky, thank you.
Thank you. Thank you, everyone.
Bye, everyone.